I hope you agree with me. We couldn't have had a more inspiring opening to this meeting. And I truly feel each of us would leave this meeting armed with information that they can help within their own community and scientific reach and medical reach. Now, I would like to introduce the first panel of our scientific program, Key Social Drivers Affecting Mental Health and Substance Use. The panel will be moderated by Dr. Maggie Alegria, who is the Chief of the Disparities Research Unit at Massachusetts General Hospital and the Morgan Institute, the Harry G. Leonard Jr. and Lucille F. Sarr Leonard Endowed MGH Research Institute Chair and a professor in the Departments of Medicine and Psychiatry at Harvard Medical School. Dr. Alegria, I welcome you and the panelists for this session to come and take your seat at this stage.
Okay, we're going to start the first panel, and I have to say this is probably one of the hardest jobs to follow Dr. Vivek after that incredible presentation. But let me start this panel. This panel is going to be about social determinants of health, and we're going to concentrate on social determinants of mental health for youth. And so you'll hear many things. This is a terrific panel. Please don't leave because it's just amazing. Let me start by starting with the unequal treatment report. There's many reports down there. I had the honor of participating in that report, and I want to touch upon what we found were the impediments of progress. As you can see, policies fail short, including we have an attack now on prevention, failure to pursue promising venues of research, failure to invest in promising solutions, overemphasis on treatment sickness. There was not much prevention that we saw. A complex and fragmented healthcare system that we have heard for today, and pervasive racism in healthcare. I wish that the leaders that are here have an opportunity to really change the trajectory that we've had, and in the 20 next years, we don't find what we found in this report. Next. Let me go to tell you why do we need a new agenda. I think we need a new agenda because it's critical to complement what we have in terms of a dominant model of really individualized pharmacological treatments in mental health. We've been too long using that type of model. We need to focus on structural factors. We already know that issues that have to do with education, wealth, poverty are really central in our communities and affect the chances of youth to have good mental health. And finally, I'm going to vouch for many of what people have said today. We need to have community-based approaches, ones that really break down the barriers to get to care early enough so that we have more equitable and accessible care. Next. Let me quickly say, and this has been said by not only Victor, but by many, we need to have a public health approach. There's no way that with the few visits that people do to mental health care, we're going to make a change. Next. I want to also say, we have to, in 2022, I wrote a paper about making sure that we optimize the opportunities for community mental health and reducing disparities. And that includes focusing on social determinants like we will be talking today. It includes things like school-based services. Most of our populations of color really receive care in schools. So we need to move out of the clinics and into the community. And that might require also as a way to reduce stigma. We know that stigma is a big emphasis in today's people not going to care and youth not going to care. And then community-based approaches, like issues that have to do with incorporating mental health in after-school programs. We need to move mental health outside the clinics to the community to make sure. And like Vivek said, including more paraprofessionals. Next. Let me just say that I'm going to skip this in the effort to make sure that I present the 4 incredible panelists that we have today. But social determinants are really transducers of the biological aging that we have today. Next, let me tell you about the panelists that you'll be hearing. First is Tami Benton. She's the Frederick Allen Chair in Child Psychiatry at Children's Hospital in Philadelphia. Please read her biography. Next, we have Joshua Gordon. He's the chair of the Department of Psychiatry at Columbia University. Next, we have Douglas Gentile. Please read their bios because I'm chopping them in very short messages. But he's the Distinguished Professor of Psychology at Iowa State University. And then we have Yasmin Hurd, who is the Ward Coleman Chair in Translational Neuroscience as a professor in psychiatry. And please give them a round of applause because you'll see what a wonderful presentations they have. So we're going to start with Tami. Everyone's going to speak for 8 minutes, and then we're going to have a discussion. And then finally, at the end, we are going to open it to the group for questions. Tami.
Thank you. Can we advance? Thank you. So thank you for this opportunity to share with you some information about the state of where we are with children's mental health. And I want to start by saying that this crisis is not over. Next slide, please. Next slide. Next slide, please. I thought it would be helpful to start by giving you some sense of the scope of the problem. Oh, thank you. It's very important, we've learned with technology, that young people like to engage in their own mental health when they want it. So I just thought I wanted to provide you with the scope of the problem. And so we talk about children as special populations, but they actually make up about 22% of the US population. There are over 77 million children in the United States. And then we also know that a fair percentage of those young people are impacted by mental health conditions. So we know that there are an estimate of 15 million children through 2023 who are experiencing some mental health condition. And they're treatable, but less than half of them actually receive the care that they need. We also know that a significant portion of these young people are experiencing severe disability from their condition. So these aren't just kids who are anxious about their next exam and can use that to motivate themselves. These are children who are struggling to function at school and home and in their communities. And we also know that poor kids are overrepresented among this group. So kids who are living at the level of 100% below the poverty level are kids who are at the greatest risk for mental health disorders. I just want to give you just a brief background of what we've observed during the pandemic. So I wanted to highlight that prior to the pandemic, we were actually seeing pretty significant challenges with children's mental health. So I am still a clinician. I work in the emergency department. We were struggling with boarding of children in pediatric hospitals and emergency departments prior to the pandemic. During the pandemic, we started to observe more kids coming in more severe condition. There was increased rates of suicide for kids presenting to the emergency department. They were presenting at younger ages. And kids who had been doing well prior to the pandemic deteriorated to the point that they were seeking emergency and hospital-based services, and we couldn't provide them. So children were languishing in emergency departments and pediatric hospitals waiting for mental health care. We saw some significant trends that were concerning. We saw higher rates of suicide attempts and greater severity. We also saw a higher rate of handgun deaths by suicide for young people during the same period. These factors resulted in the decision by the Children's Hospital Association, the American Academy of Pediatrics, and the American Academy of Child and Adolescent Psychiatry to declare a state of emergency for children's mental health. And we were not alone. We were joined by 70 other organizations. And timing-wise, it was timely that the Surgeon General actually issued his advisory around the same time. The purpose of this declaration was to garner national focus and attention by healthcare providers and by our nation on this crisis of children's mental health. And it was an effective intervention. But the one thing that the pandemic did for us, well, the pandemic actually did a lot of things for us. It generated a lot of distress, but at the same time, it really motivated us to find new ways to provide care. But it also provided an opportunity for us to focus on the disparities that existed in healthcare for marginalized populations. And when I refer to marginalized populations, I'm referencing those individuals who are affected by factors that are far beyond their control, such as economics, their social environments, their communities. But we know that the factors that derail healthy emotional development are disparately impacting marginalized populations. And we know what those things are. We know about poverty and poor living conditions, exposure to trauma and adversity, which poor kids are much more likely to experience, and they're much more likely to be severe. We also know about victimization, bullying, community violence, stress on parents, and parents who are stressed to the point that they are harsh parents who engage in neglect and abuse. Loss of caregivers, which was disproportionately impacting minoritized youth, particularly young kids. And then there's the other social factors. What we've been seeing with marginalized populations, specifically LGBTQ plus youth and other minorities that have really escalated since the pandemic. And of course, as Dr. Alegria mentioned earlier, we were able to see highlights in the disparities related to racism. The impact of the events of the pandemic were not proportionally distributed. And so what we saw is that for Black, Latino, AAPI youth, Native youth, and those identifying as sexual and gender minorities, they experienced significantly worse effects across multiple areas during the pandemic and after the pandemic. The other thing that I wanted to highlight is the impact that we've seen recently on the mental health of girls, who are disproportionately impacted. Many of you may have seen the CDC data through 2023, through 2021, published in 2023, that reflects that girls overall are doing worse in almost every area compared with boys. We're seeing increased sexual violence. We're seeing increased sadness and hopelessness among girls. We're seeing increased suicide attempts. We've seen more girls, particularly among marginalized groups, with reports of forced sexual violence and physical aggression. And so what we're seeing even now is continuation of the trends that we were seeing before. And strikingly, we noticed a significant increase in suicide among Black girls between 2001 and 2017. The rates increased about 182%. So the good news, and there is good news, is we have interventions that work. So we have hundreds of psychosocial interventions that help young people who are struggling with mental health conditions. We also know what the community moderators are, and the environmental moderators are for supporting mental health. And I suggest that we focus a lot of our attention on what we can do to promote mental health and to prevent mental health conditions. We know that supportive families, supportive institutions, good school relationships, peer support, having a sense of belongingness, healthy communities, being able to get out into green space, those things are not things that cost healthcare dollars that promote health. And the enablers are the communities where kids live, in schools, at their primary care practices, in recreational activities, and things that we can do in the environment to promote mental health. I just want to highlight a few things that we learned during the pandemic that supports our capacity to expand access for kids who actually need help and for us to engage in health promotion. We learned that having a continuum of care is important. We've learned that integrated care, where we're able to expand capacity of mental health providers, make a huge difference. And we also learned about ECHO, which enables us to knowledge without moving people, and tiered school-based mental health programs. Telehealth was an enabler that allowed us to reach more kids, and the 911 access line and other digital health technologies has really expanded the capacities for young people to access care very quickly. And so I just want to highlight a few opportunities that I think we'd benefit from focusing on following the pandemic. And it's really our opportunities to expand access and capacity through digital health and technology. And I won't read this whole slide because I don't have that much time, but I will highlight the things that I think are some of the major enablers we should pay attention to. Digital health and technology allowed us to reach more people. It also allowed us to reach families. So kids that I'd been treating for months, I saw them at home with their dog and their parents and their siblings. And that is how treatment has to be provided for children. We also have the capacity to reach counties where there are no mental health providers. 70% of counties in the United States do not have a child and adolescent psychiatrist. And so I think that we need to use these technologies for clinical care, learning about our patients, developing culturally sensitive techniques, and being able to do research, learning more about our patients. And I will end my comments there.
Douglas, please.
So I've been asked not to bore you with a lot of statistics when I could do it with thought experiments. And we are behind the rest of the world in looking at things like gaming disorder, social media addiction, internet addiction, whatever aspect we want to focus on. The World Health Organization included a gaming disorder in the ICD-11 as a bona fide mental health disorder. When we look at prevalence studies, depending on the sample population and the tools we use and where we set the clinical cutoffs, we get different rates. But the meta-analyses seem to suggest somewhere between 4 and 8% of adolescents are suffering with gaming disorder. Is that a big number? Well, that means 90-some% of kids can play games, be on social media, these different technologies without it causing serious dysfunction in their lives. But if we look, there are about 50 million children in the U.S., 6 to 17. If we just limit it to, say, daily gamers, 66% would count as that. And we take this lower prevalence from the meta-analyses of 4.6%. That's 1.5 million children taking serious damage to areas of their lives today because of the way in which they're gaming, and they're not getting help because DSM-6 isn't out yet. And I'm hoping it will include gaming disorder, but that's not a certain thing. If we took a similar approach with estimates of social media disorder, it's a somewhat approximate similar number of still over 1 million children taking serious harm in their lives. And why is that? Why are we so far behind the rest of the world? Well, one analogy I think is apt is that we're kind of stuck in the 1960s, because back in the 1960s, the early research seemed to show that a medical model for alcoholism made sense. It seemed to run in families. There were certain particular risk factors that we could predict. There were some protective factors. People didn't just seem to get out of it on their own, but with appropriate help, they could get over it. But in the 60s, the country did not want to look at it as a medical problem. They wanted to say it was a moral failing. You're just not strong enough, right? That's where we are today with technology addictions. That we're still saying, and the research seems very similar. It doesn't seem to run in families as much, although there hasn't been much research on that. But there are some very predictable risk factors. There aren't a whole lot of really well-known protective factors yet. That it doesn't seem to just go away on its own for a lot of kids, but with appropriate treatment it does. So it looks like a medical model would be appropriate here, but the culture is still stuck saying it's a moral failing, only it's a little different. It's a failing of the parents. They're the problem. Now, I don't want us to have to wait 50 years to get where we've gotten with alcoholism, where everyone agrees, yes, this is a disease, or at least a disease model makes sense for a way of working with it. So let's look at a further medical analogy. that we have a patient who presents with a bacterial infection and the doctor prescribes antibiotics and they're going to be taken for 10 days. Now, we can have a couple different ways this goes. One is the patient is compliant and takes the medication as intended, and that cures the bacterial infection. And this is a beneficial effect, obviously, for the patient. Could be that the patient, after 3 or 4 days, starts feeling better and says, I don't need to take the rest of these. And so many of the bacteria are dead, but the strong ones aren't, and they can regain strength and become resistant to antibiotics and ultimately really be devastating for the patient, or if it spreads as a bacterial, a resistant strain of bacteria, that's harmful to society. So if we think about these technology disorders as similar to an infectious disease, complete treatment would look like this. It would involve all the parents, teachers, and children in an area, provide information in a really useful and patient-friendly way, and convince the children that it's in their best interest, so they're on your side, participating and compliant with their health care. Partial treatment would be we just target a few people who seem to be the problem. We provide information to them the way pointed-headed academics like me usually do. And we just try to tell children this is the right way to do it. This is what you have to do. Now, there's absolutely no scientific evidence at this point to support the hypothesis that partial treatment might be harmful for people and society. But I think it's an interesting question for us to consider. What would a complete treatment look like? How would we get the culture to agree that this is a problem worth facing head on and providing resources for trying to help these children who are having this problem? And it's not just children who have this problem. I'm a child psychologist. Yes, I know I look older. You came for the dad jokes, right? Isn't it? But I tend to focus on children and adolescents because that's where my training is. But these technology addictions aren't only harming children. So with that, I will pass it on to you.
Well, thank you. And Margarita, thank you for inviting me here. Thank you, everyone, for being here. And thanks to my esteemed colleagues on the stage. I'm going to focus in on one particular aspect of the mental health crisis, which has been already discussed. But I think looking at the data, we can get a sense of some of the specifics that I think are helpful. So this is a chart probably most of you have seen, and if you haven't, hopefully you'll be a little astounded and offended. This is the chart of suicide death rates for all ages over the last 20-some-odd years. This is from the CDC. The last data shown on the slide is 2021. 2022 data continued that uptick a little bit so that the data is about where it is in 2018. What you can see is for those 20-some-odd years, suicide rates overall have been rising pretty inexorably until 2019 and 2020. And we could talk about why that happened, and I will focus on 2020 in a little bit. But overall, the message is quite stark, right? In the United States, people have been dying by suicide at higher and higher rates, despite increasing recognition of the problems. If you look at youth, though, these numbers are even starker. There's several features that I want to point out. So on the bottom is the suicide death rates for 10 to 14-year-old kids. And they are low, which is, I suppose, some good news, but they've more than doubled in that same time period. Teenagers and young adults have also seen increases. If we go back for a moment, I'm going to go back to that dip in 2020. So everybody predicted, and I apologize if you're one of the everybody who didn't, that suicide death rates would increase during the pandemic, when actually they fell further. It's not because there wasn't suicidality, there was. We saw that data earlier. But there were also supports in our society And if you look at the data, although you can't really link it to suicide deaths per se because they're such rare events, when you look at the effects of societal interventions like eviction moratoria, extending welfare benefits without requiring complex requalifications, and other things that were put into place during the pandemic, they helped mental health. We know that because we can compare places that did it versus didn't and look at the effects of when these policies went into place on indicators of mental health, and they had profound effects. So a lot of the social determinants that we're talking about today can be dealt with, as Tami mentioned, on a structural basis. But those things didn't help our young adults. Right? There's no dip in 2020. There was a dip in 2019 and went back up in 2020 and then skyrocketed thereafter. So like we said, like others have said, there is a crisis in youth mental health. But the other thing is that this crisis did not start in 2020, as was also alluded to. These rates have been climbing for at least a decade at alarming rates. And so looking at these other factors, right, beyond the acute increase in loneliness and isolation and the economic challenges of the pandemic, we have to look at these other things for factors in suicides in youth. And we also have to look beyond societal supports and understand why those things didn't correspond to similar decreases in youth suicide rates. The good news is there are evidence-based approaches to suicide prevention. Now here in suicide, we tend to think about prevention as more what we might call secondary prevention, right? Trying to reduce suicides in individuals who are at risk. This is a schema that indicates all the opportunities for intervening, put out by some colleagues of mine at Columbia. The thing that I want to focus first and foremost on is on the right side of this graph, the left side, screening for high-risk individuals. And it turns out screening is really, really important and needs to be applied universally in healthcare settings. Why healthcare? Over half of the people who die by suicide have seen a doctor in the preceding year, and in fact, over a quarter have seen a doctor in the preceding month. And suicide is most often not a super impulsive act without a period of time where people are contemplating beforehand. So most people will answer yes if you ask them about suicide. There are screeners that have been developed. This one was developed at the institution I used to be at, the National Institute of Mental Health. There's a screener that was also developed at the institution I'm at now, Columbia University. These screeners are available. They're quick. They're easy. They're being improved by the application of technology. So this is a study that showed that you could institute a computerized adaptive screener that could really, with very high specificity improve on identifying individuals at risk for suicide, youth individuals in healthcare settings. And then finally, to add a note of hope, technology really does afford us the ability to reach children on a broad scale, but also find temporal resolution. Because even if the predisposition or risk for suicide is something that's evident over weeks or months, the acts of suicide attempts are more impulsive, are in the moment. And chances are the youth is not sitting in a classroom or a health system when they're in these moments, and we need to be able to reach them and help deliver treatment to them in that moment. And so studies showing that ecologically momentary assessment, so assessing for suicidality in real time through technology, and then delivery of intervention can reduce those risks with a much finer time frame. So for suicide as its component of the youth mental health crisis, we have to recognize, number one, these rates have been going up for at least a decade. Number two, that we can reach them by identifying individuals at risk. And number three, that we can harness technologies to reduce that risk, but it requires a concerted effort and lots of more research and resources. Thank you.
Thank you for inviting me to be on this panel. And for me, it was ending with substance use disorders. And call it the vulnerable brain. I have no disclosures. Only disclosure really is, the aspect of problematic substance use and substance use disorders that really are a reflection of despair in our society. And we know from a lot of the numbers that have been discussed earlier, it's a huge economic burden on our country or throughout the world. I mean, in the US, trillions of dollars are spent yearly on substance use related illnesses, so that the healthcare system really is under siege. There are not treatments for most substance use disorders, but for those that there's treatments for, many of them are still not used or perhaps not even suitable. And we talk about, overdose, especially when it comes to opioids, but deaths and substance use-related deaths are now over 600,000 people die yearly. I think that these things are missed. A lot of it because of the stigma, as discussed earlier. Many people don't seek treatment, and many people blame that the individuals who suffer from these disorders that it's a choice. But over 30 million people in the U.S. suffer from a substance use disorder, diagnosed. Problematic use is much more, and we talk about the individuals, but the families, the communities, and the country itself and beyond are really so critical for how the impact of substance use disorders have. Importantly, we know that there's a high comorbidity between substance use disorders and mental disorders. In fact, we have nearly, depending on the substance use and the particular substance and the particular mental health disorders, it can go up even to over 60%. Yet still, we often treat these as separate brain disorders, and even clinically, as was discussed earlier, even the treatment of individuals who suffer from both disorders, the practices that are done for that are very separated. So when we think about psychiatric risk and addiction risk, we think about the adult. But we now know that they have a developmental origin, not just adolescence, but also even from a prenatal perspective. And absolutely, we know that early life stress, the trauma, abuse, and the environment make a huge difference to this risk. And the earlier, the higher the risk that are seen. Many substances contribute to this risk. I'm going to focus today, because of lack of time, on cannabis. And I focus today because we know a lot about the developmental effects of alcohol and tobacco and a number of other substances. And cannabis has a high comorbidity with psychiatric disorders. And today, their daily use and near daily use of cannabis is actually higher than alcohol. So we don't know that much about cannabis, but one thing that we do know that is really critical at basically every step of neurodevelopment. During early stages, it's important for developing the hard wiring of the brain. And as you get into late adolescence and adulthood, it's important for that final fine-tuning of the prefrontal cortex and the maturation. But we also know that during these developmental stages, that people, especially during pregnancy, women are using cannabis more, and a lot of young people of reproductive age are using cannabis. Breastfeeding, a lot of women also continue to use cannabis. And in adolescence, of course, that time period when many people experiment anyway, those are the times also, and these numbers are lower and are growing. The question is, what are the long-term impacts? So the reason cannabis is a big issue to also consider among the other substances is that the psychoactive component of cannabis, THC, has been increasing over time. So THC now is the plants that are being raised, or I should say manufactured and grown, they are very, very potent. There's over 500 chemicals in these plants. Most of them, we still do not know their psychoactive properties. They're now highly concentrated strains, as I mentioned, and high potency products, and access to large various I would say, products, and the cornucopia, I call them, of products that kids and obviously adults have access to and varied routes of administration. We also have synthetic and semi-synthetic products that are highly potent that, again, are not being really understood or researched, yet still this is being consumed. So what do we know in regard to the developmental effects of cannabis? So for us, one of the things that we wanted to try to get a sense of, I'm a neuroscientist, and how do I look at the brain, and especially on the molecular level, during in utero? And one of the things we decided to do is actually take a look at what we call the third brain, the placenta. And as most of you know, this audience, I'm to tell you, one of the most critical temporary organ that provides life to the developing fetus. But one thing we do know is that the programming of the placenta is actually essential, not just for neurodevelopment, but for psychiatric risk later in life. And so when we can sequence the placenta, and one of the things we saw is that in women that use cannabis when pregnant, the endocannabinoid system we could see changes there. But what was surprising to us was the degree of immune-related changes. The immune-related changes were very profound. We even see sex differences where the male placenta showed much greater changes in these immune dysregulation that we've looked in another cohort as well. But importantly, my research, we do translational studies, so it's not just in humans, we also study animal models, and we could replicate this by giving the pregnant dams THC. And we saw the same thing, that it was the male placenta that showed a much greater dysregulation, especially in regard to the immune system. Still trying to figure out why. But the thing that was also interesting is that we followed the children after birth. And one of the things that we could see, there are many different behavioral changes, but we could see that there were significant increases in anxiety and aggression in the kids for here when they were 4 years old, associated with prenatal cannabis exposure. But interestingly, the placental transcriptome, especially the immune transcriptome, predicted their anxiety behavior later. And the anxiety we could also see with their stress hormone levels were higher and other stress measures. But really important, this study was actually, Yoko Nomura started to look at prenatal stress. And what we could see was that prenatal stress, the mothers that had prenatal stress and prenatal cannabis use, the synergistic huge effects on anxiety and aggression in their kids. What about adolescence? Adolescence is really critical because it's 90% of adults with substance use began in adolescence, and 25% of teens have cannabis use disorder. We know that this is also critical for psychiatric illnesses. Here, data from Denmark. In looking at over the past 2 decades, there's an increase in schizophrenia that was associated with the increase in cannabis use disorder in their society that was linked to more THC products, higher products in their society. And there was a sex difference where more males were showing this cannabis use disorder and higher schizophrenia. We can also do that in animal models where we give cannabis to the adolescent rats and look at them later in life. High stress hormone levels when they are isolated stress. So they have their little COVID isolation too. They are much more stressed in regard to their reward sensitivities higher. They show decreased social interaction. And we can look in their brains and we see a number of different changes related to their behavior. One just emphasizing in the amygdala brain region important for emotional regulation and stress responsivity. Subpopulations of a particular cell, the astrocytes, that's also important for inflammation, significantly change. And those cells correlated to their decision making and their impulsivity. So it's really critical that we understand a lot of the aspects of these drugs, not just cannabis. Yes, cannabis because we don't know a lot, but there are biological sex differences that exist from early. And the immune and metabolic function are really critical. So I know we're going to talk a lot about, what are strategies, but the educational programs, we've heard about a number of them, but national strategies are essential. And I will say, studying the brains, I can tell you that what we see are these epigenetic changes are profound, but they mean that they're reversible. So we do have a chance to actually make changes. So we must catch up. Thank you.
So we're going to go to 12:15 because we started later, and we are going to start with some questions. I'm just going to start with some questions for each of the speakers, but then I'm going to open it up very quickly. Let me start with Tami. Tami, we hear a lot of youth feeling worrisome about telling them about the mental health problems they're having to their parents. And we see them trying to refrain from that communication. What do you think we could do to make sure that youth are able to communicate to their parents about what's happening to them early enough so that we can intervene?
That's a really excellent question. It's important. Excuse me. I think it's important that when we think about youth mental health and youth mental health treatment, that we recognize that youth exist in the context of families. So their primary ecological environment is their family. And so when we work with children and families. I think because of billing structures and other barriers that impact providers, we find ourselves focusing on treatment that's focused on the child without the family. And we've kind of gotten away from the recognition that you can't effectively treat children without treating the primary environment. In my work in suicide prevention, you rely on the families to keep kids safe. And so it's important that in the context of evaluating any child who has any mental health condition and looking at treatment or any prevention-focused interventions, that your primary interventions are around finding supports for families. And part of that requires you to build communities for families. So what we're starting to see is that kids who are presenting with anxiety and depression, particularly the younger children, right? Because we're starting to see kids as young as 5 or 6, presenting to the emergency department, the factors that are impacting the behaviors that result in those visits are very much related to stressors that are occurring within families. So I think that many times, I'm a child and adolescent psychiatrist. In that work, our work requires us to work with families, but I think all providers, all clinicians need to engage families in thinking about treatment. I think we do that a lot less with adults. But it's really a key driver for mental health outcomes for young people.
Douglas, I want to ask you a question. There are commercial interests in addictions. And we've seen that, in gaming, for example, that you talked about. So does the fact that the profits from addictions are now legal, because there's a lot of legalization of this, change the landscape? Do you think it's going to change the landscape?
Well, I think certainly there was just a report, I think, in the New York Times, got some internal data from TikTok showing how they've recognized how quickly addiction can happen on their platform, and doesn't seem like they're doing a whole lot to change that. We have to look at the financial incentives. That as long as everyone is making lots of money off of more time spent, then that attention economy, it's going to be hard to change it. So we need to have perhaps some regulations in place. We should certainly be getting more information out to the public about the actual addictive potential of these types of issues. And I think that's where the biggest problem's been, is that right now the culture doesn't even believe this is a real issue. And so until we've got people saying, no, we want changes here, and we want companies to be more responsible, and we will reward them for being more responsible, it's going to be very hard to change.
Thank you. Josh, you were director of NIMH for a while, and so I'm going to ask you about whether you think the research on the availability of guns have contributed to the increase in suicide, and is that a fact that we know for sure or not? And if we don't, why haven't we focused enough attention to that?
That's a great question. I'm glad to be able to answer it in my current capacity. So there's a couple of issues there. First and foremost, and you alluded to, but to make explicit, half of those deaths are from guns. Half of the suicide deaths are from guns. And I'm not even going with homicide deaths, which is a whole other thing. Half the suicide deaths are guns. Secondly, we know that means restriction, particularly when done on a nation-level scale, can be an effective way to drive down suicide rates. We've seen this in countries like India, which used to have most suicide deaths resulting from ingestion of fertilizers. And they put controls on the distribution of fertilizers nationwide, and it drove down suicide deaths. So you put those two facts together and you say, well, half the deaths in the United States from suicide or from firearms. If we could put some controls on access to firearms, maybe we could actually drive suicide rates down. Now, you asked a more pointed question, which is, do we have the research? And in some ways we do, and in some ways we don't. So as you may know, the National Institutes of Health and other federal agencies are prohibited by law from studying the effects of gun control policies. But that doesn't mean that some of that research doesn't happen anyway, even in some ways indirectly funded by these agencies. So one study that I remember in particular looked at death rates, and I apologize, I don't remember if it's suicide, homicide, or a combination, by guns in counties in California that are adjacent to Nevada. Now, California and Nevada's gun access laws were very different at the time. They may still be. And what they did was they looked at the rates of death by guns, again, I can't remember suicide or homicide, related to the occurrence of gun sale events that were legal in Nevada. So these were punctate moments in time. And they found that immediately in the weeks after these large events that happened at fairs and things like that, death by guns went up in the adjacent counties in California. So yes, there is no question we have compelling data to suggest the easier it is, and of course these gun sales they don't require the background checks because they are one of the exemptions. Maybe they do now, I don't know, but I don't think so. So no question we have compelling data to suggest the availability of guns, the easy availability of guns, results in more deaths.
Thank you so much. Yasmin, some of your work focuses on the impact of cannabis exposure. How does this evidence relate to the current policy debates, such as ones regarding the legalization of marijuana? What's your view?
That's always a very galvanizing question, one that I do get a lot. And I will say the National Academies just put out the report on cannabis. The cannabis report just came out, and I was privileged to serve on that committee. And it's clear that we need more federal oversight because the current policies are really statewide. And that has created a number of loopholes that some of the data that I showed and the products that are there, the Farm Bill of 2018 that created that hemp was legal, and now people could make new products that are intoxicating products. So CBD hemp is not intoxicating, but you can change the chemical structure to make delta-8, delta-10 THC, and you can even synthetically make other products from the plant that are not, quote-unquote, illegal. And those are the problem in the sense of, I don't think we should criminalize substance use. I do think that the money that goes to locking people up should be used for prevention, education, and research. And I think that the problem with the lack of federal leadership in this is really challenging, and I think that legalization, as I said, I don't think we should criminalize, but I think how things are made legal has consequences, and we see significant mental health consequences of these high potent products that are now nowhere close to the original plant that people consumed even 2 decades ago when it was like 4% THC, you now have products 60% THC and even can make 90% THC, and that's what kids are using. And we see more mental health challenges because of these products that was not really seen in the same extent before.
Thank you so much. So now we want to open the floor to questions. We really want to make sure that we have a lot of questions. The only thing I'm going to ask is please refrain from comments, because sometimes we get such long comments that we don't have enough of a chance to give everyone an opportunity for questions. So we would love your questions, and please try to be brief so we can invite more people to ask questions. Yes?
Who's first?
Hi, I'm Joan Luby.
No.
No?
Oh, no,
Joan
no.
Luby, child and adolescent psychiatrist from Washington University. Building on what our incredibly wise Surgeon General had to say and what these panelists had to say, and thinking about the escalating mental health crisis, I'm thinking that there's two things that the medical profession has not paid enough attention to. One is the greater income disparities in our society and the fundamental resources that people need to be able to thrive and be mentally healthy, which we could make recommendations about and are not well defined by the current poverty line.
Thank you.
So the question is what the panelists think about that.
Agree. Oh, yeah. Okay.
You want to talk? Yeah.
Yeah, could you repeat the question so that I make sure everybody heard it?
I'm sorry?
Could you repeat the question because...
Yeah, the question was, that the poverty line, should we extend the poverty level? So, because a lot of people do have mental health problems because of issues of poverty and hardship. And
Thank
so,
you.
whether we should do that.
Thank you for that question. So, the poverty, unfortunately, exposes kids to all the things that we know pose risk for mental health. And so the stress related to parents and the parents not having resources to support young people, the problems with community schools and schools that are under-resourced, and can't provide adequate support and supervision for communities, the exposure to community violence. And I think the exposure to community violence impacts young people in ways that we don't even imagine. So, for example, we have kids who show up in the emergency department, their parents report that they're not sleeping is the primary problem. And when you talk to the children, what you discover is they're fearful because they hear gunshots at night. And so all of those factors drive health outcomes. Access to care. We know that for mental health care, we are struggling to be able to support preventive services for families, but currently those services aren't reimbursed, so health systems can't necessarily provide them. And then for most young kids, they're either uninsured, with poor families, they're uninsured or they're insured by Medicaid. And many health systems have resorted to limiting the amount of Medicaid they're willing to take to provide those services. All of those things limit access. And then the other thing that I think we don't think about very much when we think about poverty is what are the messages that children pick up when they look around them and all they see is decay and despair. You don't see green space, you don't see parks. When I tell families, go out and exercise, and sometimes they look at me and say, where am I supposed to do that? Where is it safe? And so those are the factors. All of the things in the environment, the economics, the surroundings, education, employment, all of those things are impaired for poor families, and it's impact their mental health in adverse ways.
Josh?
I would just build on that and say that, income matters, and so do these many other factors. And we need to study interventions that think about each of these factors, both independently and together. And my colleagues at NIH are running a wonderful program to study the health benefits of various structural interventions, including green space, including economics, including community centers, including availability of quality groceries. And we're going to find these have tremendous mental health benefits.
Next.
Yes.
If you could introduce
Sam
yourself.
Silverstein, Columbia University. I'm going to ask you a question about why we in the medical profession have not done anything to improve school health. School health education in the United States is in a total state of disrepair. In New York City, there are 144 certified health educators for 1,819 public schools. Our residents rotate through the school, our pediatric residents at Columbia rotate through the school health clinics, but are never instructed that they might participate in health education in the schools. Why have none of you raised health education as a critical issue that we, everyone in this room, can do something about?
So I did raise that in my comments because I'm a big believer, especially because when you look at where are kids receiving care, and mostly youth of color, they're mostly getting it in schools, but it's so minimal. I completely agree with you. And I think part of the problem is schools, if you think about it, schools have been underfunded, and a lot of the pressure of school is to make sure that they pass the exams. And so the effort has moved to the academic domain at the expense of the psychological, emotional domain. And so if you go, and I've been working in certain schools, if you go, the resources for mental health are dismal. So we are all probably in your vote on increasing school benefits. And actually, in this 4 years, there has been an increase, but not enough to really get it to the next level.
Forgive me, but that is accusing the system of failing when we ourselves are not taking any initiative.
No, we definitely are. Yeah. Thank you. Yes.
Hi, I'm Jeanette Southpaw from Harry Medical College. When you consider the 30 to 40% of the children and adults presenting to primary care practices, whether they be family medicine practices, I'm a family doc, pediatric practices, general internal medicine practices, they're presenting with behavioral health problems. And yet what we are doing is we have separated how we pay for mental health and behavioral health conditions versus other chronic diseases. So what we have done is we have limited the way to reimburse for these types of services. And I wonder whether there's any action now at the federal level, at the state level, to try to reconnect management of chronic illnesses that are behavioral health chronic illnesses with medical chronic illnesses, because we would never say if you have diabetes you have eight visits and then the money's gone. We would never do that because we wouldn't expect to cure diabetes in 8 visits. And yet what we do is we've limited the amount of coverage for mental health services, behavioral health services, in an unusual fashion, and as a result, limited the resources. Any ideas on that?
First, let me say it's far worse than you imply. Because it's not just that the care is segregated, it's that the payment and the payments are segregated. It's, of course, that the systems for delivering them are segregated to the point where, even though we're all paying for it, the healthcare insurance companies that cover mental health have no incentive to spend more, even though it will save the healthcare companies that pay for physical health tremendous amounts of money, because individuals with comorbidities, which is everybody, right, cost the system tremendous amounts of money, right? So the whole system is not set up to incentivize investments in mental health care, which will overall reduce healthcare costs. That said, there is a lot of progress. And for example, the limits you mentioned are now illegal. They're happening, I'm sure, but you cannot limit mental health coverage in a way that you don't limit other forms of health coverage anymore. That is illegal. Still happens. There are other ways that insurance companies have found to limit access, right? Although that's not what they say they're doing. So we have a lot more work to do. But parity for healthcare is advancing, although far too slowly, and it needs more teeth. and you should vote in November because one of the candidates has been working hard on mental health parity, whereas the other candidate would not continue that. The final thing I would say about this is that there's a part of what you implied also is the integration of care, and there has been a lot of work. So CMS and most insurance companies now will reimburse for mental health care delivered in the context of collaborative care models, which were mentioned earlier as an effective way of delivering mental health care through primary care settings. There are reimbursement codes, et cetera, for providing that. So that is an advancement. We just need it uniformly covered.
Well, I would say that is something that the Academy just had a committee that I was privileged to co-chair on whole health. And the data are clear. Put them all together and get the collaborative care and we'll get better outcomes.
Yeah, I just wanted to comment in response to your statement, to support Josh's comments. There actually has been a lot of focused work in this area. And, there are multiple factors that impact the capacity to integrate these services in the primary care setting. Some of it's been billing. There has been progress in that area. Some of it is provider comfort with providing mental health care. And there has been a large focus on expanding access to that knowledge, particularly for pediatricians. So I mentioned Project ECHO, which is used in multiple specialties to educate providers about subspecialty care, but also in 50 states now, except I think maybe Idaho or Iowa, in 49 states, there are mental health access programs where primary care providers are able to get an immediate consultation with a mental health professional in order to provide care at that moment that the patient is in the office. So there really is a lot of work nationally happening in this effort, supported by our federal and the local governments. And so I think we should try to utilize a lot of those interventions more.
Yes, please.
I'm Sharita Golden from Johns Hopkins University.
Could you speak a little louder?
Sharita Golden from Johns Hopkins University. So I'm an endocrinologist and also a physician scientist. So I was really struck by the data and the animal and the human models showing that the sort of the elevated cortisol levels and the neuroendocrine dysregulation that's known to be associated with mental health disorders, social drivers of health. And so I'm wondering if there's going to be any longitudinal studies to then look to see how that informs physical health conditions. So like a lot of mental health disorders are linked to diabetes, cardiovascular disease, and those neuroendocrine underpinnings are a part of that mechanism. So I'm just curious if you're looking at your studies, the human and animal studies, longitudinally.
Yes, we are, but I'm going to say that a number of longitudinal studies, including, the new, the ABCD NIH study for adolescents and the prenatal now that's just started in terms of the HBCD. But the second panel, I think, or later, we're going to have more discussions about the stress hormones and the endocrine, because indeed, I think that, again, coming back to, we have to ourselves stop siloing. There are amazing physicians and scientists here who may not consider themselves to be mental health investigators, yet still they are. Why? Because what you just said, endocrine changes, the immune changes, the metabolic changes that we see that are very profound, and we can, like I said, replicate them in our animal models. So we know that the substances do that, and we know that the developmental impact is critical for that risk. So why are we not all educating ourselves and working together? Because I am actually not a placental expert. I was a neuroscientist, and all of a sudden I'm like, what, the placenta? These are things that I think that are very important, but the later panels will give you more insights on that.
Go ahead.
Hi, Jessica Marks, NAM. We do have some questions from the virtual audience, so I'm just going to turn to my colleague Noah in the front to ask a question on behalf of the virtual audience.
She's there.
Oh, she's there.
And then we'll turn back to the gentleman behind me. Thank you so much.
Absolutely.
Thank you. From the virtual audience, recognizing that part of the reason for expanding recreational marijuana is the social justice argument rooted also in the disparities from the war on drugs. How do we change the narrative that cannabis expansion in communities of colors may not be helping, but is actually hurting future generations? And I think similarly, what is being done to educate those in government who promote cannabis legalization?
As I said, for me, I do think education is critical. That the war on drugs did criminalize or locked up a lot of black and brown people when whites used the drugs in the same amount. And even in the states that have legalized cannabis, and we have seen a reduction in arrests, that's mainly for whites. Interestingly, the levels for black and brown people are still the same. So there's bias still even in places where so the law is one thing, but how it's applied is another. So education is really critical. And as I said, I think, locking people up for substance use, if they do criminal things is one thing, but we really have to start realizing this is about mental health. This is about wellness. And there are different aspects of cannabis. We can talk about other people in terms of we're using in terms of on the medical as a potential medicine and treatments, but it's not, for us at least, THCs, other cannabinoids. So I think educating people about cannabis and that this cannabis today is not what, their mothers or fathers, definitely not their grandfathers' cannabis. So, yeah. Please.
Hi, I'm Stephen Parker. Unlike many of you, I'm an architect, and my focus is mental health. I'm also a member of the Academy for Neuroscience for Architecture. I'm glad to be here just to learn, but I was interested in the mention of green space, and my purview is mostly the environment of care. And I'm curious as to what experiences or what you're seeing out there in your various systems around that environment of care. We've seen recovery cafes in Canada. We've seen a lot of youth crisis centers being developed across the nation, or brain labs for Austin ISD, for example, a number of different models of care and ways to address it through the environment and the quality of the environment impacting your mental health. I'm just curious if there's any thoughts from the panel on that. Thank you.
So what I would say is we need to study it more, but there are a number of good examples of understanding how that environment interacts with care. The most obvious one for kids is around making sure the care is delivered in a system that is accessible to them and which reduces the stigma associated with them. So one of the studies, for example, showed that especially Latino kids will be more likely to engage in therapy and benefit from that therapy if it's delivered in the context of schools. It's true of all kids in general, but happens to be, at least in that study, especially true of Latino kids in that particular Southern California area. Another set of studies really has been done around reaching teenagers. And although it wasn't super carefully controlled, they studied the effects of essentially locating care in the setting of malls and other community centers as opposed to healthcare settings. And they found kids were more likely to access it and engage in care where they didn't have to be seen walking into a clinic, right? As opposed to walking into another setting. So access for sure is one way that the environment of care matters. And I'm sure there are lots of others and maybe others. Thanks.
And I'm sorry that we're only going to have 2 more questions. Go ahead, please.
Hi, I'm Olivia Merchant. I'm a student at Johns Hopkins University. And you guys are talking about how when you're treating the child, you have to include the family as well. But I'm just curious about what is our plan for children who don't have families or children from unsafe families, like children in foster care, like all these different situations where the family is not really going to be the best mode of support for them.
That's a really excellent question and an increasingly significant problem. And so it's not just, so kids don't exist alone. And I think we forget that sometimes. They all exist with adult caretakers of some sort. And whomever those identified people are is the system that you have to work with children. Harm reduction for kids in foster care will occur if, one, they're not placed in foster care, because we know that minoritized populations are disproportionately impacted by family separation. And, the work to address those factors will happen by strengthening communities, providing communities for families. You know, Dr. Murthy's comments about belonging were really brilliant because that's where families struggle. Spiritual communities, whatever communities exist for families, you have to engage them to provide that support. But we are going to have to focus on two systems where lots of children are placed, foster care and juvenile justice. And those are systems in which the adults in the environment, all of us together as partners, will have to work together to provide the supports that children and families need.
Ali, you have the last question.
Thank you. I'm Ali Andrade Silver. I direct the Forum on Mental Health and Substance Use Disorders in the Health and Medicine Division here at the Academies, and Dr. Alegria is our co-chair. My question for you all is, what is the role that the National Academies can play in moving the needle towards solutions revolving around social drivers of health and other social determinants of health? Thank you.
Well, I mean, I've always found the Academy particularly valuable in synthesizing available evidence, pointing out where gaps in those evidence exist, and taking the conclusions from those syntheses and bringing it forward to policymakers. I think, and I don't think that there's anything different here. I think gaps is probably going to be the biggest factor to help identify them, and there's been work done in that space here.
And again, I think also add, I think the network that is the National Academies, it is about educating. From here, everybody goes out, and that is critical. It is about education within the community of the NAM community as well, and the impact that the NAM has in this town on policy, but really it is about the nationwide strategies that are needed, and that's what the NAM does have the ability to do.
And I'll finalize by saying the convening. I think we bring, the Academies has the chance of bringing policymakers, patient advocates, clinicians, and put them all together in the same room, even people from different pieces of government, to talk to each other about what needs to be done and how to do it in a coordinated fashion. Thank you, everyone, for being such a great audience.